Hello, everyone. So I'm Jamie. This is my senior lecture, and it's not about ultrasound, so you're welcome for that. So we're going to be talking today about violence prevention and protection in the emergency room. So just a little roadmap of what we're going to be talking about. We're going to be reviewing some aspects of situational awareness, de-escalation, your rights and reporting, and then we are going to do a little group involvement activity on some self-defense techniques that you could potentially use if you found yourself in a worst case scenario in the ER. But before you get too excited, we're not going to be doing this. This is reserved for Dr. Gore in the ER. And anything that you learn today is not at all an encouragement to engage physically at all with any of your patients. Rather, it is about learning boundaries and techniques of de-escalation so that we can avoid a situation from becoming violent. So the problem, I don't really need to spend a lot of time preaching to the choir here. I think we all know that this is a problem, and an increasing one is workplace violence, especially in the emergency department. What you're wondering if there's data behind it, there is. And so as of January 2024, 91% of emergency physicians said that either they or their colleague were a victim of violence within the past year. And 66% of physicians reported being personally assaulted in the workplace within the past year. Most of these assaults, the perpetrators are mostly patients, with a very small minority being family members. And within those patients, it is usually patients who are acutely psychiatrically ill or intoxicated. The most common assaults that occur are verbal assaults and threats of violence, followed by hits or slaps, and then the slightly more minor category, still around like 20 to 25%, are getting spit on, kicked, or punched. So this is, as we are all aware, a really real problem. And we're all really tired of it, and that's really valid. So I want to preface this by saying that what I'm going to be talking about today are our techniques, things that we can do to protect ourselves, keep ourselves from being vulnerable, and control a situation when it's happening in front of us. But I also want to acknowledge that I know how frustrating it is to get a lecture about more things that feel like your responsibility when this is a much bigger issue and the real solutions lie in systemic changes. And so not the purpose of this topic, but I do want to touch on the fact that systemic changes are the real solutions to this problem, and the data backs it up that systemic interventions such as improved screening for weapons, getting patients changed into gowns, taking away personal effects, is something that's going to improve or lessen the risk of violence in an emergency department. Things like changes to emergency department structure to limit patient proximity, things like addressing the boarding crisis where patients spend a prolonged period of time, again, in proximity with other patients. And the prolonged period of time also leads to increased agitation of both patients and their family members. Things like physical barriers and separated patient-provider areas. I think every one of us has felt this weight lifted off our shoulders with the barriers that have been in place in the pod. Just this like little bit of sense of relief and safety, knowing that somebody is not going to be coming up to that counter, spitting at you, yelling at you, throwing things at you. Just having that physical protection is huge. So I think that's a really big systemic win for our department recently. Things like improved communication, trust, and consistency between providers and security and hospital police, and things like zero tolerance policies and emphasis that people will be removed from the emergency room if they assault staff, whether verbally or physically. With the caveat that we work in the emergency room, and unfortunately, a lot of the times the people who are becoming violent are people who cannot really be discharged. They are a danger to themselves, they are a danger to others, they are acutely ill. And so that obviously is going to be a caveat to that zero tolerance policy. But in those cases where somebody does not medically need to be in the ER or a family member, Kings County does have a zero tolerance policy that we could probably improve on the implementation of that. But again, these are all things that are evidence-based for reducing violence in the ER. But we're working in the day-to-day with how it is right now. So what are some things that we can do about it? So firstly, I just want to be a little bit encouraging, especially to our juniors, that you can do it, that de-escalation and dealing with agitated, angry patients is truly a skill that you gain throughout residency. This is something that stressed me out a lot as a junior. It contributed to my burnout. It contributed to my anxiety on shift. It made me want to avoid picking up certain patients. And there was just a point in my residency where I dealt with the situation and then I was like, oh, I'm better at this than I used to be. It's a very real skill within emergency medicine to learn how to handle these situations. And in general, they become less mentally and emotionally draining over time as you learn how to navigate them better. And so I do encourage you, just don't shy away from picking up agitated patients. I know it's uncomfortable, but it is a really, really big part of your education. And the best time to do it is when you're earlier in your training, because you always have the support of your seniors and your attendings. When I say this, I also want to preface that with, you should not be in a situation that you're incredibly uncomfortable with. If a situation is escalating, you need to bring that to your senior or attending's attention. If you personally feel like you are being attacked, victimized by this patient, if there are things that are specifically making you uncomfortable, please escalate that to your seniors and your attendings, because it might be best both for you and for the patient to just have you removed from that patient encounter. But this should be a team effort. And in those cases where you tried, it didn't really work, just pay attention to how your seniors and attendings then handle that situation so that you can learn moving forward. So the first thing I want to talk about is situational awareness and some prevention things. We all learn about alarm fatigue, but I think especially at Kings County, we have a little bit of yelling fatigue. People are screaming all the time, and we're not always paying attention to it. I think that there are times where we're so used to hearing it, it doesn't faze us, but when somebody is yelling, that might be the time for intervention. It doesn't always work, but that is a time to pay attention rather than shy away, so that we can intervene before things go too far. Um, Things like avoiding having your back turned to agitated patients. This can be really challenging in our ER that has hallway beds facing each other. But just be aware of the board of the patients on rounds. If you're seeing a patient in 4 hallway and you know that patient in 5 hallway either was violent before or has potential for that, just have it be on your mind. Personally, I usually am wearing a long braid. If I'm like talking to a patient at 4 hallway and I'm a little bit concerned about the one in 5 hallway, I tuck my braid behind, like into my shirt, make sure that I'm not putting myself in a vulnerable position physically that way. I think that a big area for improvement for this, for us also, is when we're on rounds. I've been on rounds so many times when there's agitated patients just like storming through, and we all kind of like huddled together, and these people are walking around and behind us. And not saying that we need to like square up against these people, but I think we just need to be a little bit aware of how we're facing. If we're tucked away, not looking at this person, we want to keep our eyes on these people, and maybe make an attempt at de-escalation, even if it's interrupting our rounds in order to avoid something more dangerous happening. If you're specifically going to see a patient that you're worried maybe has the potential to be violent, things like, again, will tuck my hair into my braid, having breakaway lanyards, making sure that somebody can't grab your ID and rip it down. If you have shears on you, maybe removing those shears, anything that could potentially be used as a weapon that's on you. Wearing eye protection if you're worried that it might be someone who might spit at you. Keeping as much distance as possible. This isn't the patient that you're cozying up with and putting your arms on the bed, on the side rails and trying to talk to them that way. Not having your legs crossed and being in like a non-athletic position, making sure that you're standing wide base, so if you need to dodge away, you can. And always having an escape route, making sure that you're not putting yourself in a situation where the patient is between you and your escape, making sure that you know exactly which direction you're going to go if things were to escalate. So, and when it comes to de-escalation, this is a mnemonic that is used called the diffuse mnemonic. And so it starts with decide. So to me, this is a from afar, very rapid, very superficial assessment of, is this somebody who I can even engage with, or has this already escalated where we need to be calling in backup? So the person who is already throwing things, damaging property, throwing fists, this is not the person necessarily that you're trying to gently approach. I'm not saying don't talk to them, you still should talk to them, but you need to be bringing in those other reinforcements. This isn't really the time to engage in all of these next steps. All these photos are from county, sorry, or downstate, but you know. Next is ensure your safety. And so, within this goes the things that we already talked about, making sure that patients have their weapons taken off of them. That was a CT that was done of a patient that it's not inside of them, it's in their pocket, a knife that wasn't taken away from them. And this is why Mark is really big on making sure patients are changed into gowns. So it's very valid. Making sure the patient doesn't have any weapons, you don't have anything that could be used against you, and having an escape route. I use this photo for escape route because I think it's hilarious. You can get really creative with your escape routes, but just make sure that you have some way to go. Form a relationship. So introduce yourself. Just saying your name, that you are the doctor. Establishes you. This is why I go by Dr. P. It's a lot easier. So just introducing yourself, identifying yourself as the doctor kind of automatically is potentially aligning yourself as someone who can help this person. You don't need to go into, big storytelling and really trying to get to know this person on a deep level. We're just talking about, identifying yourself, acknowledging them, and introducing yourself. Utilize interests. So in general, people fall into two categories. Oops. The first category, people being people who are angry and upset and can be reasoned with and are angry and upset for some reason. Whether how valid that reason is, we're not gonna you're not the judge of that necessarily. But sometimes it can be something as much as small as an intoxicated patient that really wants a sandwich. And giving that person a sandwich can de-escalate and prevent violence. Sometimes it's a family member who's getting really agitated in everyone's face because their family member has been sitting in the hallway boarding for 3 days. They soiled themselves and no one's cleaned their mother in 3 hours. Like, that's a really valid reason for someone to be upset, and they might be coming to you just saying, hey, I need an update. And these people, it's just like, check your own biases. I know it's really hard. I know we're really stressed, but talking to these people like they are people and understanding that they may have really, really valid reasons for why they're upset, or they might just have a really simple solution like a sandwich. That can be the solution to this problem. And I think that I've been surprised over the years how many times this works. Like, truly, people are upset about something, you address it, you help them with something, and everything gets a lot better. I think things like, it's okay to apologize for things that aren't your fault. I'm sorry you've been waiting so long. I'm sorry that they've been sitting in the ER this many days. I'm sorry your team hasn't updated you, and offer whatever information and help that you can. Just make sure you're following through on it. So the person who wants an update and you're like, okay, yeah, I'll call your team, and then you never call, that's actually going to escalate the situation down the line, because the most angry family members I've seen are the ones who say, yeah, 3 people already told me that, and I haven't seen one person pick up the phone. So just make sure that if you are promising to call S1, 1126, it's really easy to get in touch with them, let them know about the patient, just follow through on that. And then next is kind of our second category of patients. And so sometimes people cannot be reasoned with, or you can't find I know these really disturbing, annoying patients. Sometimes you just have people that, whether it's that what they're upset about is they can't articulate it, or they're just so intoxicated or psychiatrically ill that you can't really engage in that full conversation with them. The next step is to set limits. And so you've tried a full conversation, you've tried to find a solution to their problem, you can't find it. The next step in assessing how this is going to go is to set very clear limits. And this is a skill I think I gained as I went through residency. I was not very good at it as an intern, but things that are very, very clear, short, stern boundaries. No, you do not talk to our nurses that way. You do not speak to our staff that way. You cannot use that language here. Things like, I need you to sit down in your bed. You must sit in your chair. If you do not sit in your chair, we cannot get your medications. I cannot help you. Sit in your chair now. Someone who's moving around and putting the nurses at risk while they're trying to get an IV, stop moving your hand. You're going to injure yourself. You're going to injure your nurse. Stop and stay still. Again, I've been surprised at how many people who I thought were never going to get riled in, when you're just so stern with them, they listen. And not always, but it's a really big step, because people who don't listen, people who you are giving very simple, easy instructions to, boundaries, authoritative boundaries, and they are not respecting them, or not able to respect them or understand them, that has tipped you now into a category that this is somebody you have to be more wary about. This is somebody who may end up requiring sedation if things start to go badly, because you've already kind of exhausted all of your limits of communication. And last is just enforce and evaluate, which is just kind of the next steps of whatever pathway this has led you down. Just so you know, the rights and reporting. So like I said, we do have a zero tolerance policy at Kings County. I think we can improve upon the enforcement of that. But we do have these signs that are up in the emergency room that tell patients and tell family members that this zero tolerance policy exists. And then on PeopleSoft, there is an area for reporting. So anytime that you, either yourself, although it's hard when you are the person who's now dealing with the acute stress of an event, maybe your colleague can go and report events, because that's the way that we can make systemic changes, is by making administration aware in writing about what's going on. And NYCHAC also does have this Helping Healers Heal program, so that if you are involved in a violence situation, it's just a resource for you for support and mental health care moving forward. So you utilized all of these things. Either things happened too fast, they caught you by surprise, escalated in a way you didn't expect, whatever it may be. You find yourself in the worst case scenario. I'm talking specifically about work, but this is New York City, and any of this can literally happen on your way to work as well. So I just want to introduce some very, very, very basic self-defense that you could potentially use if you find yourself in a bad situation. You are not Jackie Chan and you are not Dr. Gore. And so I want to emphasize that the goal of introducing these techniques, again, are just as a way to get away if you find yourself in a bad situation. The worst thing you can do with self-defense is having it make you really overconfident and making you think that you can approach somebody, you can stay in a situation because you know how to get out of it. And the only way that you can actually do that is if you are like truly, truly in martial arts. And this is not something that we should be engaging in at work. If you do not have the proper training and you try to fight, you're probably more likely to end up looking like this. All right, so we're gonna do a demo. James is gonna come down and help me. And if you guys want to stand up and get a little space, get a partner, we're all gonna practice this. So,
I need my sandwich.
So the first scenario we're going to talk about is a really common way that people are grabbed, and this is also very common, like out in the street, not necessarily in the emergency department, is if he were to grab my wrist with one hand. So my instinct when a grab like this is going to be to pull this way, and if he's stronger than me, it's not going to work. I'm not going to be able to rip my hand out of his grip. But what I can do is use the weakest point of his grip to my advantage. So I'm going to turn my hand so that my radius is along the weakest part of his grip, and then I can rip out that way. So you're always just trying to use the weakest part of the grip there, if you guys want to practice it. So now let's say he's being a little bit more aggressive. Let's say you have someone they grab you with two hands. Now he has two hands on my arm. This is a very difficult position for me. If you try to pull me, it is very hard for me to resist this. But again, we're using the weakest part of his grip and utilizing what is strong for me. No matter how big he is, no matter how strong he is, his thumbs are not stronger than my entire upper body. And so in this case, I'm going to make a fist with this hand, grab my hand, my fist with my other hand, and pull out this way. And like truly have your partner hold you as hard as they possibly can. You're going to be able to get out of this grip. So two hands. So we'll move on to another one. So if somebody is approaching you, coming towards you, you don't have any way to back up behind them, and they put their hand on you, like on your shoulder here, and they're trying to grab you and control you by grabbing your shoulder. Again, you're just using the strongest part of you against the weakest direction of theirs. And so in this case, you're going to take the heel of your hand and you're just popping their hand off of your shoulder that way. It puts you automatically in a defensive position where you can pop off and run and go. And this one is helpful as well because it's also useful if someone were to go at your neck. So if you were to try to grab my neck, again, in that direction, I can use one hand, pop and make my escape. Do one more. So this last one is like a really, really bad scenario. Somehow you ended up in a situation, it is you, the patient, and the exit is behind them. So let's say that door is my way out and James is in the way of me getting there. And so you need a way to be able to get around your patient. And in this scenario, let's say he's swinging at me. So if the person you're going against, like studies kickboxing or Muay Thai and they punch you the way you're supposed to, this isn't gonna work. But most people who engage in fights, in bar fights, and who don't know things, they're going to punch with a long swing around the side. That's how people feel like they get the most power. And so this is going to be very like against your instincts. This is something you have to practice and think about over and over again. And most of the time in an adrenaline fueled situation, this might not be your instinct. I just want to introduce it to you as a first time option. So if James goes to punch at me, my instinct might be to go away, this way, guard my face, whatever it is. But actually the best way for me to protect myself, he swings at me, is to come inside and block his shoulder and his bicep. He's not going to be able to reach around and hit my face. And so I come here, and it also gives me a position where now I can escape around him. So if I have him blocked here, I can come around this way and get away and get to the door. So this one's a little bit more complicated. It's kind of just for fun that I'm introducing it. But again, if we're doing it this way, he punches, I come in, I block here, and then come around, and I can get my escape. All right, so I'll just get to the end of the lecture here. So again, this is just meant to be like a really, really simple introduction to a couple of techniques. Again, the worst thing you can do is be overconfident, but I want you to have some ideas, some tools in case you to end up in this situation. These are not going to be necessarily your first instincts when the adrenaline is pumping. So think about these things, practice these things. And honestly, doing martial arts has been a really, really cool thing that I've done in residency that I didn't expect. It's something that has made me feel more safe at work and also just at all times in the city. It's been a really cool way to use my brain in a more like meditative body movement way rather than the like chaotic intellectual way we have to use it at work. And it's been a really, really cool balance for me. So I highly recommend go to as many self-defense classes as you can. And if you're at all interested in starting in martial arts, let me know. I'm happy to give you some referrals. This is my dojo. I have to give thanks to them as well for helping me prepare for the self-defense aspect of this lecture. These are my references, and it is a senior lecture, so I have to give my thanks. So I want to thank my family coming to New York for residency. One of the things I was most excited about was being back closer with my family. Getting to see my many nieces and nephews grow over these past couple years has been amazing. And being close to my parents who are so incredibly supportive. Will probably move to Colorado in a couple years for me, which I would be stoked about. So I'm really, really grateful for them. For my second family, which are my friends, some of whom I've had since I was in kindergarten, some of whom are from med school that I'm really excited to go back to in Colorado. But all of these people, it really takes a village, and they have all supported me in ways that I cannot explain over these years. I want to thank our attendings. You all invest a lot in us over these years, and I feel like it must be really challenging, the fact that like residents are coming through and through, and you have to continue investing in people year after year, and I think that must be exhausting. But you all spend so much time helping us grow, helping us learn, not just medicine, but how to be better doctors and how to be better people at Kings County. And to our APDs and Dr. Willis, like you guys do, you have an impossible job. Like the system is working against us, the system is working against you. And I truly have felt like cared for and listened to over these entire 4 years, and we all really appreciate that. And lastly, to my class, I mean, you guys are just, you guys have been absolutely fantastic. I could not have asked for a better class. It's kind of crazy to think about the like life that we've been through together, like truly breakups, new relationships, family deaths, new babies. When life has gotten hard, we've been there for each other. When work has gotten hard, we've been there for each other. And I think one of the most incredible things I think about all of you is that I truly, truly would not be the doctor I am today without you guys. I like since intern year, you guys have inspired me, you've motivated me. Everyone has such like unique interests and unique skills that that I feel like I've been taught throughout the years. And I truly think that we are all better doctors because of each other. And I am very, very grateful for that. That's it. And funny pictures.